Hey, hello. My name is Hee-moon. I'm a member of a CP server and IMG from Korea. Today we are having a teaching point recap. Unlike our usual morning VMR, the teaching point recap allowed each member to choose a topic from the past month to highlight key points and reinforcing learning through space repetition. It's my pleasure to welcome three outstanding guests, our new member, Kashar and Patricia and Johan. Let's begin by introducing these wonderful individuals, starting with Kashar, who is already presenting for the second time. Kashar, please introduce yourself and share a wonderful case.
Hi everyone, I'm Khashayar, medical student from Iran, and let's start the presentation. So I'll be presenting a case presented on September 23rd in VMR with Alec and Austin. The case was the story of a 63-year-old man who presented with diffuse myalgias and arthralgias and chills. The initial presentation was pretty unspecific, but further history showed a history of multiple tick bites, which really focused us on the possibility of tick-borne diseases. But during further workup, we were faced with a positive blood culture of MRSA, which led to a final diagnosis of reactive arthritis with the MRSA epidural and psoas abscesses complicated by osteomyelitis. During the case discussion, we addressed tick-borne diseases extensively, and here I wanted to go deeper into Staph aureus infections and bacteremia specifically, deeper because it's one of the perhaps most important infections in, especially in hospital settings, and it's more on the rise recently in the communities. 20 to 40% of healthy people are colonized with Staph aureus, and this makes them especially dangerous in a hospital setting. This infection can present in a constellation of different symptoms and patterns, and because of that, we need to be familiar with all of these different presentations so we can approach the treatment properly. I'm going to first start with a pathophysiology of this infection and then go on to all of these different presentations and finally finish with how we approach the treatment. First, with the pathophysiology. The most important part of this infection is breach of cutaneous or mucosal barriers. This is the first and perhaps the most important requirement for the infection. This can be from something as small as a skin abrasion to something as severe as an IV injection. Something like a skin abrasion may not lead directly to an infection, but it leads to colonization, which is a precursor to infection. So keep it in mind. This is the first step. After that, the infection itself starts. This infection has a tendency to form abscesses, and this is the result of the initial intense infiltration of the PMNs as a response to the infection by the body. It has mechanisms that it can evade the host responses. Some of them are because of its capsule, which induce abscess formation and give it anti-phagocytic capabilities. It also has mechanisms that allow it to survive in the intracellular environment. Before moving on from the pathophysiology, I want to address that because of the importance of the PMNs and neutrophils specifically in this infection, diabetic patients are especially vulnerable to this infection. Now, let's look at the different presentation. The first kind of presentation is skin and soft tissue infection caused by staph. It is the second most common cause of surgical wound infection, and its risk factors are shared across all the different presentations we see. One of them is chronic skin disease, again, going back to the breach in the cutaneous barrier. Chronic skin diseases like eczema and rashes and other things can make them vulnerable to this infection. And Skin breaches, right, like insect bites and drug injections, can be the most important things that I want to focus here. Insect bites were the cause of bacteremia in the case that was discussed, and injections are the most common cause of the infection that we see in a hospital setting. And one thing to keep in mind is that injection drug use is not limited to recreational drugs. Insulin is an injection drugs that many patients use and makes them vulnerable to this infection. Another form of presentation is respiratory infections that are especially important in intubated patients. The reason it's especially important in them is that this infection has a tendency to form biofilms that make it especially effective in causing infections of medical devices and allow it to form polymicrobial infections which can respond not as expected to the treatment that we put it on. Another form is the infection in infants and children that can lead to presentations with pneumatocells that lead to pneumothorax and emphysema. Another form of presentation that we saw here was osteomyelitis that show the tendency of this infection to metastasize to many places in the body. Here, especially in adults, we see a metastasis to the vertebra. It can present itself as intense back pain and fever or chronic back pain with low-grade fever. Our diagnostic tool here, the most important one, is MRI. Septic arthritis is another form of presentation, and we saw that in this case as well. In both children and adults, Staph aureus is the most common cause of septic arthritis in native joints. And our diagnostic tool here is joint aspirate, which show us a turbid fluid with more than 50,000 PMNs and a gram-positive cocci when we do a gram staining. Finally, perhaps the most important kind of presentation here is Staph aureus endocarditis and bacteremia that can present in four main ways. First one is a right-sided endocarditis that is associated with injection drug use. It is often accompanied by pulmonary emboli. The reason here is that most of the injections that the patients use, be it recreational drugs or medicinal drugs, is in their veins. So if you follow the path, you see that the right side gets affected first. After that, we see a left-sided native valve endocarditis. This happens usually with antecedent cardiac valvular damage. It's not common in native healthy valves, and it has a worse prognosis compared to the other one. Next, we have prosthetic valve endocarditis. This is especially fulminant in early postoperative period. And finally, we arrive at the nosocomial endocarditis. One thing to keep in mind here is that these infections commonly happen in a setting where patients are already on antibiotics, so our blood cultures may come back negative and the diagnosis may be missed. Now that we know all of these different kind of presentations, let's see how we approach the treatment of this infection. First and foremost is the documentation of infection, which we do with two positive blood cultures that are more than 24 hours apart. And while we document the infection, we have to identify whether this is a complicated or uncomplicated infection. I'll come back to this part. Uh, Before understanding that part, we have to identify the focus of infection for the treatment. First and foremost, we have to rule out endocarditis, as if missed, it has a tendency to recur and complicate the case with a failure to respond to treatment. So let's see what we mean by an uncomplicated infection. Uncomplicated infection of Staph aureus happen in patients who have no implant prostheses, have a removable focus of infection that is properly removed, and they have no evidence of metastatic foci. With all that, they have a prompt response to antimicrobial therapy, which is seen with no fever or positive blood cultures after 3 to 4 days of therapy initiation. We usually treat these patients with 2 weeks of antibiotic therapy. Complicated cases happen in those who have persistently positive blood cultures 96 hours after initiation of therapy. There are cases that we fail to promptly remove or drain and identify focus of infection, and those who have the deep-seated infections. Other than that, those who have acquired this infection in a community setting should be counted as complicated cases and are treated with 3 to 4 weeks of antibiotic therapy. And here you can see my references. I hope that I've been able to give you a generalized overall view of this kind of infection, because when we're approaching the treatment, we have to know all of the different ways it can present itself and think about and rule out all of them as we go along our course. And thank you for your attention. I hope you've enjoyed this.
Yes, that was really wonderful. Thank you so much for a wonderful presentation on Star Wars. Does anyone have any question? If not, we'll move on to our next amazing presenter, Johan. Please introduce yourself and let's start your amazing case.
Hi everyone, I'm Johan. I'm an MG from Cameroon, currently based in Barcelona and applying for IM Match this year. And I'm also a CP Solver Academy member for the last 2 months, I'll say. So, Kashara, I would like to share my screen. Can you just, okay, it's okay. I'll just do it. Perfect. So I'll do the TP recap of a case presented by Massa Mardini, one of our Academy members as well, on September 27. The case discussant were Prof. Rez and Prof. Rabi. So the problem representation. 77 years old male with a history of metabolic syndrome, recent sepsis from osteomyelitis, and epidural abscess. 2 weeks after being discharged, he presents with progressive jaundice, dark urine, and pale stool. And on key exam findings, we have generalized jaundice, spider angiomas, and 2+ bleeding edema. So, patient present with jaundice. I mean, what do you think? So first, jaundice, bilirubin is elevated, but which side? So is it direct bilirubin elevation or is it indirect? Well, if it's indirect, you think about hemolysis, you think about congestive hepatopathy. If it's direct, is it extrahepatic or intrahepatic or basically infiltrative disease? So if it's extrahepatic, you have positive imaging and you can think about stone, PSC, and cancer. If it's intrahepatic, on the other hand, the imaging would be negative, and now you have two ways. Is the problem the bile duct or the hepatocyte? You know, if it's the hepatocyte, instinctively you will think about increased AST and ALT. If it's the bile duct, you would think about increase in alk-fast GGT. So if it's the hepatocyte, it can be a viral infection, alcohol acetaminophen, and if it's the bile duct, you can think about PBC, other drugs like amosclav or infection like leptospirosis. And in the middle, you have infiltrative disease or anything that can give you cirrhosis or infiltration as well, like fibrosis and fat. But here you have other signs. Basically, you have um, it can be due to basically acute and chronic um, cirrhosis, for example, and you have signs like spider angiomas, like the patient has, hepatic encephalopathy, jaundice as well, that can be in chronic or in acute and chronic as well. So I'll go on with the first round of labs. So with our patient, the notable labs and imaging we had was increased AST and ALT at 800. ALP was high as well at 1000. Direct bilirubin is elevated, total bilirubin is elevated, of course. And on ultrasound, hepatomegaly and diffusely increased echogenicity on ultrasound. So before commenting that, I'll let the chat tell me, what do you think is happening now? Do you think it's extrahepatic? Do you think it's intrahepatic? Do you think with the spider angioma, do you think it's maybe acute and chronic cirrhosis? What do you think, guys? And you can unmute actually if you wanna share what you think. Okay, Elena is saying spider angiomas is non-specific for cirrhosis. Elena, you wanna unmute and basically say what you think about what's happening now.
Yeah, thanks, Johanna. I was actually Googling this when I saw the VMR, I think last week. What are specific signs for cirrhosis? Because we were thinking about, is this like a more chronic process that is having now an acute phase, or is this like all acute? And I think there's a few signs for cirrhosis, like for example, a low blood pressure, or I think thrombocytopenia is especially that is very indicative in the context for cirrhosis, but spider angioma are actually seen in other diseases as well. For example, chronic like sun exposure and stuff like that. Yes, and I think the high ALT and the high bilirubin really point towards a cholestatic pattern. Yeah.
All right. Thank you, Elena. And I mean, you're 100% right. Another clue will be the ultrasound finding. We just have hepatomegaly with diffusely increased echogenicity, meaning that there might be a fatty infiltration, especially since the patient has a metabolic syndrome and he's 77, but there's definitely he's definitely not cirrhotic regarding the ultrasound findings. So for that, we're good, even though he has spider angiomas, as Elena said, it can be due to other causes. Um, well, you also have the coagulation studies, the platelets are a bit low, that's true, but overall, I personally don't think it's an acute and chronic cirrhosis. And I have this second scheme for from CP solvers, and also knowing that um, the ultrasound findings are overall negative, we can basically think about intrahepatic cholestasis and not extrahepatic, since the ultrasound findings are negative, and also about infiltrative process. It's unlikely, basically because of the ultrasound findings as well. We just have an increased echogenicity that can be due to simply fatty infiltration in a patient with metabolic syndrome. So about the AST and AST-ALT and ALK-FAST, a really important point is that if the patient comes pretty late, you have the AST will be decreasing and the ALK-FAST will be increasing at the same time. So you will think that, hey, maybe this patient just have, let's say, bile problem and the hepatocytes are fine. But no, you first have to rule out all the differential linked to hepatocyte problem, basically an injury at that level. So for that, you have toxins like acetaminophen, infection like viral hepatitis, shock liver, for example, especially in a patient who got sepsis a week ago, autoimmune hepatitis and Wilson disease as well, for example. And for cirrhosis, we're able to rule it out. And for bile duct, you have to rule out PBC, that we rule out with imaging as well, other infectious causes. For example, for infiltrative causes, we're able to rule it out. But a really important teaching point here is that, hey, yes, it's intrahepatic, but you still have to dig, right? Is it the hepatocyte or is it the bile duct, So let's continue here. In this particular case, why did we suspect DILI pretty early on, Because when you have the imaging, if the infectious causes are negative, like you do the viral hepatitis panel, it's all negative. On ultrasound, the hepatic artery is fine, hepatic vein is fine, everything is fine. You rule it out as well. The autoimmune causes, you're able to read out. And now what do you have left? Well, you have DILI left because it's a diagnosis of exclusion, right? So now you have to look for a temporal association, right? So if a patient is basically doing the same thing, he didn't change anything in his medication, well, you will double check other things before thinking about DILI. But hey, this patient has sepsis recently and he was put on cefazolin and he was already on amiodarone for past medical history causes, right? And these are drugs that are really hepatotoxic. So when you suspect DILI, the first thing you will do is stop the offending agent, stop these drugs. And if you have a drop in AST and ALT, now you can say, hey, this patient had DILI and we stop the offending agent. And especially in a patient like him with basically maybe an underlying, evolving liver process with the fatty infiltration that can maybe put him in a place where he's more susceptible to hepatotoxicity. So this is it's a simple approach of DILI that I created, based on this case. So first you define the liver injury pattern. So is it hepatocellular, cholestatic, or mixed? Like our case, we had like increase in AST and ALT, and then increase in alk fast at the same time. With the clues you have from the history and exams, so any new medication, alcohol use as well, systemic illnesses, the physical sign, you have jaundice, he had spider angina, even though it's not super specific, it's still a common sign of liver problem. So it still indicates you that there's something going on. There might be something going on with the liver and push you to the obviously the jaundice as well. And you prioritize key differential diagnosis. So you don't rush to DILI right away. You have to rule out all the other causes before thinking about DILI and looking for an offending agent. And when you were able to pinpoint an offending agent, you can basically remove it and see if the patient is improving to say, hey, okay, this patient had DILI. So some clinical reasoning pearls: always consider DILI in polypharmacy, especially in older adults with multiple comorbidities. To confirm the diagnosis, DILI is a diagnosis of exclusion. You have to look for a temporal association and a response to treatment, basically amelioration of symptoms after withdrawal of the offending agent. So regarding this case, that will be it. If you have any question, feel free to write them in the chat, or if you have any comment, feel free to unmute. Thank you.
Okay, thank you, Johan, so much. It was a fantastic presentation. Does anyone have any questions? Yeah, yesterday during our practice session, Patricia delivered really outstanding presentation. But right now, like unfortunately, we face the internet issues and we are not. Are you there? Is she here? No. Okay.
No.
Okay. Yeah, so we are not able to connect. I hope she will have the opportunity to present next time. And well, so this will be the end. Thank you for tuning in. I would like to conclude with this: work hard and be kind, and amazing thing will happen. Especially, are we hearing something? Especially to those applying for the match. And have a great day and wonderful. It was really wonderful presentation. Bye, guys.